All right, welcome everyone. We're delighted to have you all today for our third Big Heart panel related to mentoring. And so I'll introduce our guests in just a moment, but just wanted to orient folks and welcome folks into this virtual space today. And as we get started, just want to acknowledge that at the University of Washington, that we learn, teach, work, and live on or near the unceded ancestral lands of the Coast Salish peoples, the land which touches the shared waters of all tribes and bands within the Duwamish, Puyallup, Susquamish, Tulalip, and Muckleshoot nations. We pay our respects to the elders, past and present, whose ancestors have resided here since time immemorial. Coast Salish peoples and many other Indigenous peoples continue to thrive in these lands, alive and strong. For those of you, if this is your first time attending a Big Heart session, we're welcome. And if you've attended others, we're so glad to have you back. Just a little bit about Big Heart. This is a program that is funded through our Center for AIDS Research at the University of Washington and Fred Hutch. It provides opportunities specific for undergraduate and graduate Indigenous scholars who are interested in learning more about HIV research. These different sessions take the form of seminars and other opportunities, and we also focus on mentoring as well for folks across the training programs that are interested in learning more about mentoring, with a specific focus on mentoring Indigenous scholars. For undergraduate and graduate students, we engage in opportunities where they can connect with HIV researchers and those also in sexual health across the field of HIV science at different events, learn about different internship or job opportunities. And in particular, for those who have attended multiple events and are Big Heart scholars, we provide support to attend the annual Principles of STI and HIV Research Public Health Practice course, which is a fantastic learning opportunity. So if you are an undergraduate or graduate scholar interested in learning more, please feel free to contact us and check out our website where you can register to become a Big Heart Fellow. So as I mentioned, today is about mentorship and our mentoring series, but we also have our sort of larger topical series in Big Heart with our next speaker, who's coming up at the end of this month. Harlan Pruden will be coming down from British Columbia, and this will actually be a hybrid in-person and virtual session. And we're excited to hear him talking about relational accountability and being in good relations, Two-Spirit and Indigenous health research as a state of reconciliation. So please, if you haven't already put that in your calendar, we have the information here to join us for that in just a few weeks. But today we're super excited to have two fantastic researchers here with us in this virtual space, Dr. Angelique Day and Dr. Christopher Kemp. I'm not going to do a big introduction on them both, but because I'm going to let them give some time to introduce themselves and their work and anything else they would like to share with us today. And so as a reminder, we'll kind of let them talk for a bit and have some conversation. And if folks have specific questions and want to share, we'll open up to a larger conversation as a group as well. So in the meantime, let me stop sharing my slides. And I will turn things over to Dr. Kemp and Dr. Day, whoever would like to launch things off first.
You want to go for it, Angelique?
Oh, I am happy to start. Just cut me off. I did not time my talk, so I'm apologizing in advance for that. So just let me know, when I'm at time, because I want to make sure that Dr. Kemp gets the time that he deserves for his presentation as well.
Absolutely.
All right, hopefully everybody can see that.
Yes, looks great.
So wonderful. And because I'm not quite sure of the time of this, I'm not going to spend too much time on introductions. But, just want to say, this has been a great opportunity and partnership with the Indigenous Wellness Research Institute and other stakeholders who have been involved in this initiative. This particular area is near and dear to my heart. I am a former foster youth. And have personal experience in the system, the specific system that I'm going to be talking to you about today in Michigan. So also wanted to preface, this is secondary data analysis of state administrative data. We did take some time to look at the Indigenous specific population, but that number is 27. So I'm calling out, we looked at it, but to answer my research question, I needed a larger data set to do this with the methods that were needed to answer the question. So we're centering and thinking about those 27 individuals that make up this larger data set. Okay, and there are two folks in the room today who are my, co-authors that are part of this study. So I wanted to give them a shout out. So welcome today, Dr. Paul and Shoshana, who's a newly entering PhD student in the UW School of Social Work. So super excited to have her jumping on so early in her research and learning process here at the university. And then an undergraduate student who is not here today, but wanted to acknowledge his participation and lens that he brought to the process. All right, so to frame this issue, because we're looking at sexual health risk behavior, including pregnancy and STI among a sample of foster youth in Michigan's foster care system. So just to center this study and the importance and value of this study is to understand what is the sexual risk-taking experience as a foster youth compared to other adolescents in the United States. And so if you look at teen sexual health behavior nationwide across the United States, you'll see patterns of pregnancy rates actually have gone down in time, but STI rates have gone up in more recent years. If you look at foster care specific population compared to the general adolescent population, you'll see that contrary to non-foster care youth with foster care experience, or FCE, as you'll see throughout this note today, have continued to experience high levels of risk for pregnancy, repeat pregnancy, and sexually transmitted infections. And that this particular discrepancy is not a surprise, because certainly having a history of sexual abuse and other forms of maltreatment have been linked to adolescent sexual health care risks, which makes foster care youth particularly vulnerable. We also know, looking at the foster care population, that young women or girls living in non-relative foster care settings, family-based settings, as well as facilities or congregate care, and those with runaway history in the foster care system are also more at risk to experiencing pregnancy than youth with foster care experience living in other placement types. And that's a lesson learned and a hat tip to the Indian Child Welfare Act, because young Indigenous young women are more likely to be in kinship care. And so that is actually a protective factor for that specific population in the out-of-home care. We also know that placement moves, that greater placement instability is associated with higher pregnancy rates, and that young people, especially teenagers in the foster care system, experience greater placement mobility than younger kids in the child welfare system. One of the other things that we've noticed for states that have adopted extended foster care, that means the ability for states to continue foster care placements for young people up to age 21 rather than ending at age 18, has led to reductions in pregnancy rates. And as I said before, among those who identify strong connectedness with their caregivers, including those in kinship care, again, those young people, we've seen less pregnancies among that population. Okay, moving on now. So this particular study is really looking at contraceptive care and access to contraceptive care for young people who have foster care experience. So just to share definitions, that contraceptive care for this particular study is defined as having access to preventive treatments for unintended pregnancies and the transmission of sexually transmitted infections. And there are several types of contraceptives that exist across the country. Each type of contraceptive has its own side effects, levels of invasiveness in terms of use, and effectiveness. And certainly different types of contraceptives are more or less accessible based on the type of insurance that a young person has to support access to these resources. One other thing to note is as science has improved and more effective strategies have come out in terms of preventing pregnancies, we have seen an unintended consequence of populations of teens decreasing use of condoms because they're relying on, pregnancy prevention. And we know that condom use is really the #1 way to prevent STI infections. So we've seen unintentional consequences of movements in pregnancy-related prevention that has led to more risk behavior in terms of STIs. We also know that contraceptive care is certainly multifaceted and includes many things in terms of accessing contraceptive care, including screenings, education, counseling, different types of contraceptive provision. And with each of those comes with different levels of follow-up care needed from physicians and other healthcare providers for management, evaluation, and determining any changes in care, including removal or discontinuation of different types of contraceptive devices. Many contraceptives require different levels of involvement of physicians, different levels of frequency of visits, and many have different periods of effectiveness before they expire. And some are better suited for patients that change healthcare providers more frequently or experience more mobility and are unable to stick to a regimen, which that is of a particular sensitive issue for young people in foster care who don't have stable family lives and experience mobility a lot within the child welfare system. So this particular table is from MWebD, just giving you an overview of the different types of contraceptives, the different types of procedures that align with each of the types use, and the frequency in which that care has to be revisited and or prescription refills and or doctor visits. This frequency encapsulates both types of care continuity. It's important to talk about Medicaid in the context of contraceptive use for foster care youth because virtually all foster care youth qualify and are covered under Medicaid at point of foster care entry, regardless of health insurance status prior to foster care entry. There are important policy implications in terms of Medicaid and the policies that dictate use of contraceptives under this policy. Specifically, Medicaid regulations require that states provide a comprehensive set of healthcare benefits to children and youth up to age 21. But unfortunately, there's no specific language in this federal mandate that requires coverage of pregnancy, STI prevention, or reproductive health care services as this service is applied to young people in foster care. But states can choose to have more generous guidelines than what is guided by the federal government. In Michigan, where this particular data set was obtained from, does have a Medicaid manual that does suggest that those types of services should be covered under Michigan Medicaid policy. In fact, this Michigan Medicaid manual says that the state should cover family planning services that includes supplies for sexually active minors of childbearing age. So that's a reference from that manual. There are a couple other federal policies that exist that align well with Medicaid and what should and should not be covered. So for example, the Foster Care Independence Act, which is part of Title 4E of the Social Security Act, establishes that Medicaid continue to be available for former foster youth between the ages of 18 and 21 who have aged out of the system, meaning they did not experience permanency before turning 18. And there have been 24 states out of the 50 that have extended foster care to age 21. And for states that have extended foster care policies, they can also serve young people with Medicaid under their state until the age of 23. Finally, the Patient Protection and Affordable Care Act, as of 2014, requires states to provide Medicaid coverage to emancipated youth upon reaching 18 to extend that coverage up until their 26th birthday. One of the things that this particular study looks at is how does Medicaid impact contraceptive care access with different types of Medicaid insurance. So this study looks at the differences between access to contraceptive care, looking at whether or not a young person has a managed care plan or a fee-for-service plan. And just to clarify what that means, fee-for-service plans, pay participating physicians, clinics, hospitals, and other providers a fee for each type of service provided. So some of the concerns about fee-for-service is that this can lead to volume regardless of a healthcare outcome or quality of care. But folks that are not fans of fee-for-service say that it can lead to fragmented care and redundancies in care and gaps in care. And so these arguments were made when the HMO movement came along. And so the health managed care organizations have built strategies that they have argued control costs, improve quality, and access to care. HMOs include standards for performance, and that is for a wide variety of practices within Medicaid, which include revenue generation, volume of number of participants seen, monitoring utilization of medical technology, and use of special consultations and referrals. Now, it's important to understand that when these HMOs first came out, there was a hesitancy to put foster care youth on these types of plans, and that they have initially, and in some states, continued to be exempt from HMO eligibility. And there are some good reasons for that. One concern was that HMOs reduce spending by limiting access to needed medical care rather than reducing wasteful care. And foster care youth as a whole are high-end users of healthcare services. And so one of the worries of having foster care youth on this plan is that they wouldn't get the full access to benefits they need because they would be spotted in the system as being wasteful care users. And that their high levels of healthcare utilization could be misinterpreted as excessive spending by managed care plans rather than a reflection of them actually having greater healthcare needs. The other reality with foster care youth that makes them vulnerable in terms of HMO access is that foster care youth lack parents who can be reliable healthcare advocates on their behalf. And so they're easy targets for across-the-board reductions in healthcare by managed care plans because there's no one to argue on their behalf. Okay, but despite this debate in the healthcare system of what type of insurance is best for foster care youth, Michigan Public Act 131 of 2009 actually changed health insurance coverage for youth with foster care experience from fee-for-service to HMO, and that this policy mandates enrollment of foster care youth within 14 days of foster care entry. And again, this is regardless of whatever health insurance they had prior to foster care entry. So looking more deeply at this issue, although covered by Medicaid, the Michigan Child Welfare State Manual with specific reference to contraceptive treatments, including access to birth control, this is an excluded category from required routine non-surgical medical care procedures. And again, Medicaid covers it, but this is the Child Welfare Manual now. So this is how it's different from what I talked about previously. So this means that child welfare workers and foster parents are not required to assist youth with foster care experience in accessing contraceptives as part of their case planning process. And it's also important to understand other policies impacting and governing the state and in terms of young people accessing care. For example, Michigan state law, only a married minor under the age of 18 can get a prescription for birth control without a parent's permission. So if you don't have parents, this can greatly impact your ability to access contraceptive care. So now let's talk about the current study and what we're trying to discover. So we know from combing through the literature that information linking contraceptive type or use among youth with foster care experience is pretty limited at best. Following youth with foster care experience to examine their sexual health behavior, access to their sexual health care over a period of time across varying placements. This has never been done before. So this study is the first of its kind to be able to answer, what does that actually look like for this population? And there is an absolute need to identify patterns of contraceptive use and youth with foster care experience, especially because this is a high mobility population. And we know that, as we stated earlier, the choices of contraceptive care require more or less accessibility to healthcare providers over different frequencies of time. So we need to understand, what does this look like for this population? This study is the first of its kind to link interagency data, and I'm talking about state level administrative data, child welfare records with Medicaid records, to examine the types of contraceptives being prescribed and patterns of use among a population-based sample of female youth in foster care. So it is, the sample includes foster care youth who were in care a year before this policy change, from fee-for-service to HMO through a year after this policy change occurred. So 2009 through 2013 is the duration of this sample. And this includes all female foster youth who were in care that turned 14 at some point between 2009 and 2013. So this is a whole population examination. This particular study uses a natural experiment to provide the field critical information on how insurance status type impacts contraceptive care access for this population. And again, insurance type is Medicaid in both samples, but we have a portion of the sample in fee-for-service Medicaid and a portion of the sample in managed care. So these are the different things that we were able to explore with the data set we had. One is understanding what are the types of contraceptives that are being prescribed for foster care youth, which include a variety of injection, oral tablets, skin patches, vaginal related contraceptives. We're able to examine the average days of supply for each of these contraceptive types, and are able to look at frequency of use. Our primary outcome variable that we're looking at, we defined in binary terms, specifically looking at, did the youth seek a refill before the exhaustion of the previous supply? Because you know that exhaustion looks different based on the type of contraceptive that you're using. Our primary independent variable in the sample is health insurance type, looking at HMO versus fee-for-service. And there are several factors that we controlled for in the sample, such as the age of the child at the beginning of the study period, race, geography, looking at urban versus rural differences, differences in living arrangements, and tracking placement moves over time. The analysis of this data included descriptives, which are frequency and percents for our categorical variables, and for our numerical variables, they're described using mean, medians, and standard deviations. We also performed a logistic regression analysis. Again, looking at our major dependent variable was the refill sought before exhaustion. We set this at 95% confidence intervals, and the analysis was conducted using R. So looking at table 1, this gives you an idea of the different types of contraceptives that this particular sample of young people were able to access through Medicaid. And this is a total sample, including both the young people served by Medicaid HMO, as well as the fee-for-service sample. It's important to understand that when we looked at how many young people were in our sample, we had about 4,721 young people, independent young people in the sample over that whole observation period. Only about 2,720 young people actually had access to contraceptives at any point in the sample. So again, that's only about 42% of the young people in foster care of childbearing age were had any type of claims for any type of contraceptive care. So that's an important finding in and of itself. Next, out of the 2,720 individuals who did have some level of contraceptive access, we analyzed a total of 19,668 claims of that population. So again, here, table 1 summarizes the type of contraceptive used, the average refill time, and what percentage of the time they were used. So oral tablets claimed over 77% of the time, with the average day of supply for this type of contraceptive being about 30 days. Contraceptives via injection were claimed about 20% of the time, and this type of contraceptive is effective on average for about 90 days or 3 months. And then finally, skin patches and vaginal contraceptives were claimed only 1.7% and 1.14% of the time, with average days of supply provided to users being between 30 and 33 days respectively. And again, it's important to note that these are the options that were afforded to our young people. And these are not contraceptive care options that last over long periods of time. And again, we're talking about very high mobility patients. So let's talk a little bit more about the meaning of that in just a moment. So here in table 2, you'll see that the average age of foster care youth who sought contraceptives was about 14.5 years of age, with a standard deviation about 1.9 years, and a median age of about 15 years. During the study period, on average, foster care youth changed their home about 2.5 times, so 2.5 different placements. In the data set, you'll see here that about 52% of our sample was white, followed by African American at 41%, and then other races coming in at about 6%. About 29%, or about 1/3 of the youth in foster care resided in an urban county. It's important to understand that 80% of the state of Michigan is rural. So we do see a large urban population. So during this particular observation period, about 48% of all the claims that we analyzed were during the fee-for-service period, and about 46% of those claims happened during the managed care visit, respectively. So close to half and half. Okay. Looking at table 3, this summarizes the odds ratios from the logistic regression utilizing this longitudinal data. So it's important to note that we saw that young people were 10% less likely to seek contraceptives before exhaustion in the transition period. So that's the 1 year, because of our counties rolled out that change from fee-for-service to HMO at different points in time. So we just calculated that as a transition period because we weren't able to know for sure which counties during which time did officially made that change. So that's how we described that. And young people in the HMO period were 15% less likely to seek contraceptives before exhaustion than young people in the fee-for-service period. So for the foster care population, we are seeing the fears of the reality coming out that access to contraceptives was worse during managed care than when they were being served under fee-for-service. We also see that those who lived in a family-based setting were about 37% less likely to receive access to contraceptives than young people in residential facilities. And we can see that young people who were living independently, who did not have access to an adult to advocate them, had the least access to care. So 45% less likely to seek a refill in a timely way compared to those living in residential treatment centers. And then finally, the young people who were living in the urban area were 19% less likely to seek refills before exhaustion compared to those who were living in other counties. Which runs contrary to belief, because most folks believe that urban areas, you have greater access to healthcare services than in rural communities, but we actually saw the opposite effect in this study for foster care youth. Okay, so some really important points to be discussed from this study and lessons learned. One, 42% of our sample had 0 claims over the reporting period. So we have a very large amount of foster care youth who do not have adequate access to contraceptive care, which means if they are accessing care, they're either doing it without the support of Medicaid to supplement those costs, or they're not accessing contraceptives at all. It's got to be one of those two things. So another important factor is that despite the high mobility of this population, the vast majority of foster youth are being prescribed contraceptives that require the ability to access pharmacies and doctors on a regular basis in order to attain refills. And this is a concern. So one of the things we need to work on is helping to educate healthcare providers to be sensitive and understanding of mobility status of foster care youth, and how do we coach young people to understand how to access different contraceptives types, that can keep them safe in high mobility periods where they're trying to find new doctors, new pharmacies, and oftentimes are navigating that without any adult support, which impedes access and increases risk. And we know that high mobility impacts the ability to access prescriptions in a timely way too. So it's not just about doctor's visits, it's about pharmaceutical access as well. We also know from the research and looking at general contraceptive types that IUDs require the least upkeep, and they also have the greatest effectiveness, but they are rarely being offered to foster care youth. Less than 2% of the population has access to that resource at all. And so there's some discussion about, is it that the insurance companies are refusing to cover these costs? Is that why young people aren't having access to them? Or is it because physicians aren't suggesting these as options? We do not know and cannot answer that question from the data that we have. So that is a huge implication for future research to find out why these young people are not being offered that contraceptive option. Foster youth need to be counseled to understand the best type of contraceptive for them, taking into account mobility issues. And then the other question that wasn't covered by this particular research study was looking at whether or not different ideologies of caregivers impede timely access. We see that residential treatment facilities are the best at ensuring access for young people in terms of contraceptive care. And there are many residential facilities who employ nurses on their staffs. Obviously, there are not nurses employed in family-based settings. But there might be caregivers that are less inclined to support this type of care for young people based on religious ideologies or other things, because of who tends to step up to be a provider of foster home placements. We see in this study that type of placement does impact contraceptive care access. And even if there's not an ideology into play in terms of the family-based settings, youth in independent living care had the greatest challenge in obtaining care, which just necessitates the need that young people do need advocates and supportive adults in their lives that can ensure that they get good treatments to support their good sexual health and well-being. And then again, finally, we saw that the change in type of health insurance from fee-for-service to HMO in the state of Michigan did not increase access to timely care. In fact, we saw the opposite effect, which is showing that this hesitation by states to move foster kids from fee-for-service to HMO was realized in this particular state. And so it's a word of caution to other states who have not made this change, that they may not be in the best interest of foster youth to do so. I know I went through that super quickly. I don't know if there's time for questions.